Well, greetings, everyone. I am excited that you're joining us today, and you're joining us today on what is actually an important day for me, the 30th anniversary of my sobriety. Nearly 30 years ago, I was in seventh grade, so I'm what, 11 or 12 years old? And I remember being at a church event in Fellowship Hall, and my fifth grade school teacher, Mr. Clem, he's the MC. And I remember Mr. Clem introducing me and announcing, if there was ever going to be a first female president, it would be this next young lady, Janyne Peek. Mr. Clem was one of those adults in my youth who I just knew had my back. And here we are almost 50 years later, and his words still encourage me and strengthen me. So I started drinking young, and it's about at this same time, seventh grade, I'm 11 or 12, that I had my first blackout. Most middle schoolers, most middle schoolers who get drunk, puke, and pass out, most kids learn the hard lesson. They don't like it, and they don't do it again. But I kept drinking. But I also kept getting great grades. I was selected for gifted academic programs. I was a youth leader at my church. I lived this alter ego life. By day, I'm a good student, a gifted musician, a youth leader at church, and by night as a kid, I'm drinking. And I'm 100% confident that my parents and the adults in my life, like Mr. Clem, the adults who thought I walked on water, I'm 100% confident that they had no idea. So throughout high school, I continued this dual life of a successful student, a gifted musician and leader of the high school youth group at church, while consistently drinking into blackouts. I was a strong enough student to graduate from high school a semester early. And by the time and that time between finishing high school early and starting college, it was really, really hard. I was 18. I'm told that I was independent from the time that I came out of the womb. I mean, I was living at home with my parents and I was miserable. Oh, I just remember we argued a lot those days. And one day I had been drinking at home and sneaking booze in my bedroom. And I'd been fighting with my mom all day. And she asked me to go and get some milk at the store. And I thought, that's it. And I suddenly decided that it was too hard. I'm done. So at the time, there were news reports of people hooking up a garden hose to the exhaust of their VW bugs to put themselves to sleep. And guess what kind of car I drove? My first car was an orange VW Beetle. I called it my magic pumpkin. So that evening, as my mom thought that I was going to get milk, I grabbed my boom box, I got in my magic pumpkin, and I drove to the local hardware store. And I remember navigating through the aisles and seeing a 10-foot garden hose and grabbing it and shoving it under my bulky denim coat and then staggering out of the Ace Hardware. Yet when you're about to die, stealing doesn't matter a whole lot, does it? So I drove back to my neighborhood and I parked in a cul-de-sac down the road from my house. I took the hose, I pushed one end into the exhaust, and then I unwound it and pulled the other end through that little wing window that VW Bugs had on the driver's side. I turned the key in the ignition and I sat there drinking and bawling as I recorded a message to my parents about how terrible they were, how horrible my life was, and I didn't want to live anymore. And I waited for the fumes to take my life. And I waited. Nothing happened. So I got out of the car to investigate. And I checked the hose in the exhaust and I followed it to the hose going into the little wing window. And then I went back into the car and I drank and I bawled some more into the recording and I waited. And nothing happened. So I get out again. I recheck the hose and the exhaust. And this time, when I get back into the car, I assumed that the wing window was open just a little bit too much. So I tightened it up just in case it's letting too much of the deadly fumes out. And then I continued to drink. And I continued to bawl my miserable message to my parents about how horrible they were, how horrible my life was. And I waited for the fumes to take my life. And still, nothing happened. So I get out, and once again, this time I inspect the hose and I take it and I look at it in the light of the headlights. I had stolen a soaker hose, a hose covered with holes. And by God's grace, I'm alive today. You know, it took about another decade before I found my bottom. I graduated with a degree in theater from Baylor University. I was on the dean's list, again, finished classes a semester early for college. I worked throughout college. I performed in professional theater in Florida and in Chicago. After graduating, I excelled as a young professional in a great job for a best places to work company. I almost married a guy I fell in love with in college. And in addition to my full-time job in human resources, I was a part-time director of children's music at my church, the same scenario as my youth. And at night, I drank alone. I blacked out, and eventually it got to the point where I was waking up with the shakes and discovering bruises on my body from falls in my apartment that I didn't remember from the night before. It was bad. But it's interesting, what motivated me to seek help, it wasn't the blackouts or the bruises or the shakes. For me, it was a fear of getting caught, being found out by my family. So about a decade, about 10 years or so after the soaker hose incident, I began trying out AA meetings. And for about 3 months, I went to different AA meetings. I was usually drunk when I went to them. And on May 13th, 1991, about a month before my 29th birthday, I got sober. That's 30 years ago today. And that, my friends, was the beginning of my road to health, making the day-to-day choice, sometimes minute by minute, not to drink alcohol. And in the days since then, I returned to school. I completed a master's degree and a Ph.D. I fought an eating disorder and raging ADHD. I launched a business that's been helping leaders around the world for almost as long as I've been sober. I survived the dot-com bubble burst, 9/11, and Enron, and the Great Recession. And I married for the first time at almost 50 and moved from Chicago to Omaha, Nebraska, knowing only my new husband and his family. And I'm thriving. Over the years, I've often thought about Mr. Clem's words, his encouragement. In fact, I've tracked him down to a farm in Wisconsin, and before COVID, I'd mapped out a plan to visit him and say thank you, something I'm going to plan to do when we're on the other side of the pandemic. And you know, I may not have become the first female president. In fact, I have zero political aspirations, but I have a wonderful, though often hard life. And I have a life today because the hose that I stole was a soaker hose, and because I got sober at AA. And back then, the only choice I knew was Alcoholics Anonymous, the powerful, successful 12-step program often housed in church basements. But a couple of months ago, I was sharing my plans for today's webinar on the 30th anniversary of my sobriety. I was sharing them with a friend. And she had heard Dr. Alohna Balasanova speak about a new approach to what she called substance use disorder rather than alcoholism. And along with being a substance use disorder expert, Dr. Balasanova's family immigrated to the United States from Armenia as refugees. The American Medical Association president, Dr. Susan Bailey, described Dr. Balasanova in this way. She said her past experiences have inspired her to be a passionate voice for the voiceless. Dr. Balasanova's difficult experiences as an Armenian childhood refugee motivated her to become an addiction psychiatrist and to care for patients in a compassionate way. And after medical school at Harvard and a psychiatry residency at Boston University Medical Center, Dr. Balasanova returned to Nebraska, the state that welcomed her family years ago. And since her return, she is credited with developing and implementing a continuum of addiction psychiatry clinical services from the ground up. And so today, friends, we have this amazing opportunity to learn from her. And I'd like to remind you to add any questions that you would like addressed in the Q&A section of your Zoom interface, and we'll be sure to answer them. I know that some of you are here because of your own struggles with substances. And I know for a fact, some of you are here because of your loved ones' struggles with substances. And some of you are here simply to learn. But regardless of your motivation, I am 100% confident that we're all going to learn important lessons today. Please join me in welcoming Dr. Alohna Balasanova. Welcome.
Thank you. Thank you so much. That was such a powerful story, Janyne. I'm still taking it all in.
Oh, well, thank you. Thank you. I have been, one of the things you learn when you participate in AA is to find places of gratitude. And I am grateful for the power of that story that I've been given. And I'm grateful that I stole a soaker hose. Who'd have thought? Isn't that? Who'd have thought? I always think about that when I put the soaker hoses in my gardens in front of the house here in the summer. So why don't you go ahead, Dr. Balasanova, and share with us your passion for harm reduction in the treatment of substance use disorder.
Absolutely. So I'm going to share my screen. Let me do that. There we go. So like Janyne mentioned, I came to the United States when I was very young, and English is my second language. And so language is something that I find very powerful and very important, in particular when it deals with marginalized communities like immigrants, refugees, and like those with substance use disorders. And so I'll talk to you today a little bit about stigma reduction and harm reduction, and how all roads really do lead to language. So addiction, we talk about it a lot, but what is it really? Well, it has been defined as a chronic brain disease. It has the potential for both recurrence and remission, much like many other chronic medical diseases. And it's associated with uncontrolled or compulsive use of one or more substances. We also call addiction the most severe form of substance use disorder. So the main tenets of addiction are that A, it is a chronic brain disease with potential for recurrence and remission. And most importantly, that there is uncontrolled use despite negative consequences, right? So when we think about people and we say, oh, they just need to stop drinking, right? Or they just need to stop using. Well, it's a silly thing because they can't, right? As much as they want to, they're really not able to because their brain's been hijacked by addiction. So severe substance use disorder is called addiction, as I've stated. But what is substance use disorder? Let's define that one. So substance use disorder is a medical illness caused by repeated misuse of a substance. And it develops gradually over time, leading to brain changes So it's not something that happens overnight. If you try a drug one time, you are not automatically addicted. It takes time for those brain changes to happen. And so I mentioned another term we should define, which is substance misuse. And that means the use of a substance in any way that can harm yourself or somebody around you. And the example I like to use is alcohol. So if you go out to dinner with a friend and you have a glass of wine at dinner, there's nothing wrong with that. It's legal if you're 21 and up. But that is considered substance use, right? Even though it's legal and socially acceptable, you are using a substance. However, if you were to have 3 or 4 glasses of wine at dinner and then get behind the wheel of a car, well, that is substance misuse, because now you are putting yourself at harm's way, you're putting others at risk of danger as well. So the area of the brain that is affected, there's 3 actually: the prefrontal cortex, the basal ganglia, and the extended amygdala. But the main part, this prefrontal cortex, that is what really differentiates us from our other mammalian counterparts. This is our executive decision-making center. This is where we plan out decisions and we carry them through. Well, SUD-related brain changes result in impairment in that exact area. There's impairment in your executive function. This causes problems with self-control and decision-making. So you're not able to make those healthy decisions as much anymore, and you're not able to control yourself. So the continuum is substance use, which can lead to substance misuse, which can then result in a substance use disorder, which will then culminate in addiction, which is the most severe kind of substance use disorder. So perhaps equally, or maybe even more importantly, than defining addiction, let's talk about what addiction isn't, because I think this might be surprising to some. So addiction is not a moral failing. It is not a character deficit. It's not bad behavior. It's not just poor decision-making, right? That's a symptom. And most of all, it is not a voluntary choice, something that historically has always been associated with substance use. Yet we know that science has proven that once we've reached that end stage of addiction, it is no longer a choice and that your brain is acting for you. So the language of addiction really matters. And it matters not because of political correctness, not because we're trying to be nice. It matters because it actually impacts people's ability to receive evidence-based care. Language is the context and basis of our culture. And if we use language for good, then we have the power to reduce the stigma of addiction. And the words that we choose truly matter. So saying substance use disorder, substance misuse, substance use, and addiction, right? All of those are US Surgeon General approved terms that have scientific meaning and are clinically accurate. Terms that do not have scientific meaning and are not clinically accurate are substance abuse, which really calls out criminal behavior, right? And it criminalizes what is a disease. Replacement therapy, which suggests somebody is replacing one addiction for another when they are taking a medication to treat their addiction. Calling somebody an alcoholic, which would then label the person with an illness as opposed to seeing it as a person, right, with an alcohol use disorder. So similarly with a drug abuser or an addict, that is not person-first language. We're not putting humanity before the illness, and we're just calling that person for what illness they have. And what we don't think, we think. So what I mean by that is bias and unconscious bias that leads to prejudice and stigmatizing behaviors is all around us, right? This is completely universal. It holds true for even highly trained, experienced healthcare professionals at top-notch institutions. We are all human. So we all have what I call unconscious cognitive bias. In clinical practice, this plays out like this. So there's a study in 2016 of 300 physicians at an Ivy League hospital in Boston that's very famous. And they were looking at the attitudes and clinical practices of these physicians based on, their experiences with substance use disorders in patients who have them. And what they found was that 38% found that substance use disorder is different than other chronic diseases because people who use drugs or alcohol are making a choice, which we know is not true. 14% felt that medication treatment using opioid agonists is simply replacing one addiction with another, which is exactly what the term replacement therapy calls to, right? Even though it's completely erroneous. And now this last one is the most chilling because 12% of physicians thought that somebody using drugs is committing a crime and deserves to be punished. And so I think about it as though somebody with diabetes who takes insulin is eating a piece of cake. Are they committing a crime? Do they deserve to be punished? We would never look at it that way. And yet that's exactly how the healthcare system views individuals with substance use disorders. So the language truly impacts patient care. Attitudes and implicit bias will drive clinician behavior. They've done studies where they have found that just by virtue of changing the language that is being used, clinicians are more likely to assign blame to patients when they are described as somebody that is a drug abuser versus a patient with a substance use disorder. Similarly, they agree with the need for punishment of that patient, and they view a substance abuser less deserving of treatment than if the exact same person in the exact same clinical scenario is described as a patient with a substance use disorder. Bias impacts clinicians as well, right? Healthcare professionals generally hold very negative attitudes towards patients with substance use disorders. And such attitudes are linked with lower degrees of empathy for patients. And we know that lower degree of empathy for patients leads to burnout and is a huge part of burnout for clinicians and healthcare professionals. And healthcare professionals that are burned out don't provide the same quality care. I mean, we know this. This has been proven time and time again. So by using incorrect, stigmatizing language, not only are clinicians hurting patients, but they're actually hurting themselves as well. And now, how common are substance use disorders? 1 in 7 people will develop a substance use disorder at some point in their lives. That's a lot of people. And I actually just read a statistic yesterday that said that 7% of the US population has an alcohol use disorder, right? 7%, that is substantial, right? And it is overwhelmingly common. And yet, our traditional approach to treatment has always been quite punitive. We haven't been giving people the opportunity to receive treatment in a compassionate way, right? This cartoon is a really nice illustration of people being told to just stop it, right? Give me some money for treatment, and then you stop using and we'll call it a day. And that was the traditional approach. It was based on this historical idea that substance use disorder is acute and curable. And that we remove access to the drug, right? It's time limited. Abstinence is the only goal, and everything will be okay, right? Janyne mentioned the power of community self-help groups and AA, which has historically been considered the only kind of treatment, and that's not actually even a form of formal treatment. It is a very useful self-help group, but it is not a form of formal treatment. And so to end on redefining the treatment paradigm, I know that this is a novel concept that has been gaining steam and now is considered evidence-based in the United States. And so we see Snoopy here opening up shop right next to Lucy for a lower cost, right? More cost-effective care that's only 2 cents and not 5, and that is friendly, that is perhaps meeting patients where they're at. And where they're at is going to be different depending on the person. And this is a concept we call harm reduction. Harm reduction is a conceptual and clinical framework aimed to decrease the negative consequences of substance use without necessarily reducing the consumption of substances, which I know is extremely radical and something kind of hard to take in, right? When historically we have been so abstinence oriented. And there's many kinds of harm reduction. It is strengths-based. It is not one size fits all. You meet the patient where they're at. Recovery is not defined by abstinence unless the patient wants it to be. There's no progressive steps to complete, and it's not a circumscribed program. So really, how is it different? And the main way is that the goals do not include reducing the consumption of substances, right? We focus on functional impairment and not sobriety. We aim to help people become contributing members of their community, to regain their families, their employment, housing, the entire hierarchy of needs. And we focus on what they prioritize, not what we prioritize as clinicians. So they are truly personalized interventions using a spectrum of strategies. So one example is needle exchange programs, moderation management, maintenance treatment, and of course, abstinence, if that is a patient priority. Abstinence is a very worthy goal of treatment. It's just not the only goal of treatment. And I think that is now the difference. So evidence-based treatment is a set of services that can include medication, psychotherapy and counseling, and other supportive services that are meant to help the patient regain functional capacity to its max. And again, we really focus on individuals and individual treatment plans that are personalized to what a person's needs are. Which again is just different than the one size fits all abstinence strategy that has historically been the case. Now, Janyne, I don't know if you want me to go on or to stop there because I do have a few more, but I'm also trying to be mindful of time since I know we were going to have a bit of a chat.
You're doing great here. So I have a couple questions I might ask you,
Please.
and those of you who have questions, get those in the Q&A and we'll work in responding to them. So talking harm reduction as a goal, and even I remember hearing about needle exchanges. There's a friend of our family that works in Chicago with homeless who live, underneath, in overpasses, and part of what they're doing is needle exchange and helping and having Narcan to bring them back after they've OD'd. And this whole mindset, though I'm not active in AA today, it's been a long time, I'm deeply embedded. It's deeply embedded. I'm an alcoholic, and that's any use is bad. And so I get a knot in my gut because this is so different from what I have learned, both as an addict myself and as a member of society. So that's the first thing that I just wanted. Would you like to speak to that at all?
Absolutely, absolutely. And I think your stance is completely expected. It is actually the routine stance of most people, right? Because that is how society has viewed substance use disorders. It has viewed them as something that is innately wrong with the person. And so that person must never engage in anything remotely resembling substance use because that person just can't handle that. And so they can't do that, right? And so I think what science has shown us is that the brain is very interesting. And the changes that happen in the brain are a little bit different for every person. And everybody's circumstances are a little bit different, particularly when we take into account social determinants of health, something that has really risen into our awareness as clinicians in the healthcare treatment setting. And so I think, they're not mutually exclusive, I think, self-help groups like AA and harm reduction. I don't think they're mutually exclusive. I think they can be, right, if you take the extremes of everything. But I think what we found is that when you start with the patient's goals, you later make other little goals that can nudge the patient in the direction of change. And so I'll give just one brief example. I had a patient in training who she came to me with an alcohol, a problem with alcohol. And she told me, I don't want to stop drinking, but I want to be in control of my drinking. And I said, great. So what does that mean for you? What would it mean to be in control of your drinking? And she said, well, I'm getting in trouble. She was an electrician. And she was like, I'm getting in trouble at work because I'm intoxicated. And so I've gotten into trouble. I've gotten, I'm on probation at work. And so To me, being in control would be not drinking in the morning before work so I can keep my job, right? So I can continue working and provide for my family. She was a single mom. And so I said, great, that is a fantastic goal. Let's work together to figure that out. And we started a medication that would help. We started a long-acting injectable medication, actually, one that she received a shot once a month that would help reduce her desire to drink alcohol. And so she still continued to drink, but she stopped drinking in the mornings. And so she met that first little goal that she had set for herself. So then I asked, well, do you have any other goals? Should we make new goals? And little by little, over the course of a year and a half, seeing me every other week for psychotherapy and getting her medication once a month, she went down to drinking one drink a night, one beer a night. She said she would sometimes open a second one and then pour it out because she didn't end up drinking it and it went flat. So, and that just goes to show you that with harm reduction, it doesn't mean you can't achieve the same level of change, but you just do it at the pace of the patient.
It is interesting. When I look at the continuum that you presented, and this tees up a question actually that Joni, no, it's not, that Jen has asked, so I'll tee that up. There's this continuum from use to abuse, and literally as a kid, as a 10-year-old, 11-year-old kid, my friend Julie brings, I think it was beer over, and we had a sleepover in the camper that was beside our driveway, and I blacked out. I puked the whole thing, and I picked it up again, and that was the beginning of what is it, 20 years of blacking out, and so I went from right away from use to abuse as a child. And one of the things you've talked about, so one of the things you've talked about is the genetic predisposition, which is interesting. And then Jen's question is, I've heard so many times people saying, oh, they just have an addictive personality. They easily become addicted to anything. And actually, my journey towards sobriety started with dealing with being, I'm going to use your language, with practicing bulimia, as opposed to saying I was bulimic, I think. Am I doing that properly? So practicing bulimia. And so as I began to deal with that, it isn't fun to get drunk and be sick if you can't throw up, right? So that led me towards AA. And so is there such a thing as an addictive personality? Is that a true statement?
I know it's something that oftentimes people will ask about, and you hear it all the time, right? Even in the media. There's no clinical diagnosis of an addictive personality. That being said, over 50% of your risk of developing a substance use disorder is genetic. So there is such a thing as a very strong genetic predisposition towards developing an addiction, right? But that doesn't mean you have an addictive personality, right? Personality is a whole nother can of worms, and we have personality disorders and a spectrum of those, and many times trauma underlies a lot of those types of behaviors. But in terms of such a thing as an addictive personality per se, it's not something that exists in the clinical realm of things.
So is it possible, if I put the harm reduction lens on, because I cannot imagine a day where I could casually have a glass of wine each night. The damage that alcohol did to my life, I call it reverence that I have for it as opposed to fear. I have reverence for the power of alcohol. I cannot imagine ever having a drink again in my life because of its impact on me. And so is it possible, if there had been an intervention, and I have the genetic predisposition, so have there been an intervention sooner in my life, is it possible that the outcome could have been different, that my brain, my executive functioning got wired for addiction, so I got hijacked, right? And so I guess, can you speak into that?
Yeah, well, I mean, that's a really great question. It's very thought-provoking because we will never know, right? We'll never know what could have been. And so that's hard to predict. What we do know is that certainly there are individuals who, like you have described yourself, are not able to drink any alcohol, right? Are not able to use any substances because They have perhaps tried a moderation management and it has not been successful for them. And so they have learned, the damage that it does is that really they're better off not using at all. And so again, that's still not mutually exclusive with harm reduction, right? Because sobriety can be a goal. It just has to be the patient's goal and not our goal that we're putting on the patient. I think that's the difference.
Okay. Joni Sims asked, and we talked about this a little bit when we had our prep conversation. How do harm reduction therapies help a person whose job depends on all caps, non-use of drugs or alcohol, a doctor, a pilot, a long-haul trucker, etc.?
Yeah, those are excellent questions. So right now, actually, there is a lot going on in the physician health movement front because like doctors, pilots, long haul truck drivers, many times they're prohibited from using mind altering substances, even if they are prescribed as part of a medical regimen, a treatment regimen. And so for individuals in those job settings who are not able to, take, for example, a pain medication, opioid pain medication, who are not allowed to be drinking alcohol, but who perhaps have a problem with alcohol, right? Or who perhaps have a problem with pain medications. So whereas previously they were never allowed to be on medications such as Suboxone or buprenorphine, which is FDA approved for opioid use disorder, nowadays, there are some states where that has now transitioned and physicians are being allowed to take these medications as part of a very strictly monitored treatment program supervised by a physician. And so there are situations now that, they're coming to learn that physicians are not impaired when they're taking their medication as prescribed. And so as long as that's what's happening, right? And again, it's not just in a vacuum, right? There's a whole plethora of treatment that happens, right? There's psychotherapy, there's group therapy, there's meeting with your doctor. It's not like we're just throwing a med at you and expecting everything to be great, because that's not how it works. But it's just one small piece of the puzzle that I think can be very transformative. And fortunately, I think some, agencies are starting to take notice of that.
And I do know, and Jen, Joni, if there are more questions that you have, go ahead and add those. I do know of professionals, attorneys, doctors, teachers who go specifically to support groups, 12-step programs that are for their discipline, because of the confidentiality, the support, the commonality. One of the reasons that I kept popping to different AA groups when I went is because I kept thinking, well, these people aren't like me. Those are 50-year-olds in holy blue jeans, and I'm a smart young professional. I couldn't, I didn't feel someplace that I fit. Fortunately, I landed someplace that had a blend of people, but there's arrogance that comes with it anyway. And so there are support groups for those specific disciplines. And the challenge is, how do you find those? Because they're very private. They're exclusive to those disciplines. And so it's an interesting journey to find those. I have another question. If somebody is unhappily sober and would love to be able to drink again, we call those in AA, it was called a dry drunk. If someone's a dry drunk, what would you recommend?
Wow, that's an amazing question. I've never been asked that question before. I love it. Thank you. That's awesome. So I think first and foremost, if this were like my patient, the first question that pops into my head is, why are you unhappy? Right? Where is that coming from? Is it because of not your inability to drink or to use substances? Well, what do substances do for you then? Right? What is it that you're missing? What is it that social connectedness? Is it feelings of social insecurity? Is it social anxiety? Is it other things that we can treat, right? That we have been using alcohol to replace? Because if that's the root of your unhappiness, that's easily solvable, right? And so we just have to figure out what that is, because my guess is it's not just the alcohol.
I drank before events so that I would be loosened up and comfortable enough to go to them. This was in high school. that I was doing this. So before field parties and stuff like that. And that pattern then continued. And people are so surprised when they hear that I would ever have any kind of social anxiety to go into a group because of my personality. It terrified me. And I would drink. And then by the time I get to the party, I would black out. I mean, there's horrible stories of that as a high schooler. Um, uh, Somebody here has said you've just described my husband, so that's interesting. That
Well,
there
it's
are,
very common. It's very,
yeah.
what you're describing, Janyne, is very common, that people self-medicate their anxiety, whether that's social anxiety, whether it's a different kind of anxiety with alcohol, because let's be frank, it's very effective in the moment, right? In the moment, it's effective. Later on, not so much. And it actually makes things worse in the long run.
So you talked about, and one of the things I'd like to touch on, and you can tell me if this makes sense to slide into some of your slides or to continue the conversation. I'll let you make that call. But how do we get help? And because that's what's so important. I went for a long time without getting help, and when I finally realized that I needed help was actually after I broke up with a guy that I had been dating for quite some time from college. And I described it as taking a knife and cutting a hole inside of my core and taking that relationship out, even though it wasn't healthy, taking that out and filling it with food and filling it with alcohol. And I knew I needed help. This was when I was starting to get the shakes in the morning. And then I would drink in the morning, and I'd stop at the grocery store and I'd buy Absolute vodka on the way home and drink it out of the bottle on the way home. And that was my cycle. And so I'm working in human resources and I know I need help. And so I want to go to the EAP. The EAP requires at that time a doctor's referral. I go to my doctor, and my doctor thinks I'm just being dramatic after breaking up with my boyfriend and that I'm fine. He doesn't want to refer me to anybody. And I ended up fighting within HR and saying, I need help. And this is what's happening to me. And this has to change. Now, because I pushed, I was able to get into seeing a counselor and first dealt with an eating disorder. And then that led me to dealing with my substance use disorder.
Mhm.
Yeah.
Exactly.
So I'm so curious because so much of your research comes from helping the medical profession
Mhm.
reframe how they talk about the word, not just the words they use, but the lens that drives the words they use.
Mhm.
So I guess my question then, after that long description, is um, if you go if you go to a doctor, which is one of the things you recommend, and you're not hearing what you need to hear, or you go to the EAP and you're not hearing what you need to hear, what do you do?
Yeah, that's a great question. And there are several things that I will mention that you can do on your own without reaching out to a doctor. I will just mention though, your experience is so troublesome to hear about and how your doctor treated you. I will say that in the past 20 or so years, there has been somewhat of a movement and a transformation based on our understanding of neuroscience, of the brain, and of substance use, that physicians and other healthcare professionals are more attuned to the devastating medical consequences of substance use. And so I would hope that if you were to go today to your doctor and say, listen, I'm having a problem with alcohol, that they will have help for you, right? They will not just minimize it. They will actually take it very seriously.
That's one of the
Because
questions they ask you when you go every time, isn't it? How often are you drinking?
yeah.
And
Mhm.
yeah.
Exactly. And so much has changed, right? Since your original experience. And that's a good thing. I mean, it's a good thing that we've had this change. But say you don't have access to a doctor, you don't have access to an EAP. There are things you can do on your own. So there is an 800 in the United States, there's a 1-800 number. It's 1-800 662-HELP. So just remember 662-HELP. And that is the National Substance Use Mental Health Administration hotline for seeking help in your area. So they will tell you who is available for mental health substance use treatment in your local area. And that includes, again, substance use, that includes straight mental health, that includes both. Like, say you have an eating disorder and a substance use disorder, they'll be able to help you identify somebody that can treat both of those conditions that is, nearby. to differentiate between physicians, counselors or therapists, whether you want some group therapy or a higher level of care, because those exist as well. So that is one thing. And also Googling. I know it sounds simplistic, but just Googling, your zip code or your city and addiction treatment, and, addiction treatment near me. And you should get, a list of places. Now, again, I would caution you that not every place is going to be evidence-based. And so it's important to do your research and, calling them up and asking, what kind of practices do you use? Do you use medications? Do you use therapy? Right? I mean, there are still some, kind of dubious things out there, and just always something to be aware of. And then also, like Janyne said, AA and other self-help groups can be very helpful. While they're not formal treatment, they can be life-saving for so many, right? To find a camaraderie and a community of your peers and a sober support network you may not otherwise have. And you can just Google, Alcoholics Anonymous has a website, and they have many, many groups in many, many cities, all across the country, and possibly internationally as well. And many of them are now actually online. They're on Zoom. And so they're not in person because of the pandemic. So you can participate even if you're, elsewhere or abroad or wherever. So it's never been more convenient than now.
And so that taps into that. Where I got sober, the church that I went to get sober, every Friday night, I bet they had 20 different 12-step programs. So they had everything from AA, Narc Anonymous, Sex Anonymous. They had Al-Anon for spouses, family members. They even had Kids Anonymous and Teens Anonymous. So the whole family would go and actually get introduced to the program. So that this became my social community for a period of time, particularly in the early years when I was getting sober. For those who are here today because of loved ones who are struggling with substance use, what would you suggest for them to get help for their next steps?
Yeah, so you actually just mentioned it, Al-Anon. Al-Anon is a phenomenal resource, and it's not just for spouses. It really is for friends, neighbors, anybody with a loved one or somebody close to them that struggles with a substance use disorder. Because as we all know, this isn't just an individual disease, this is a community disease, and it really impacts your family and in many ways your community. And so anybody that is affected by another's substance use is welcome at Al-Anon. And so those groups can be invaluable. And also, if it's to the point where you yourself are struggling with mental health symptoms because of another's substance use, then it would be also a good idea to maybe seek some help for yourself, right? And seek out just some counseling and coping skills, and being able to practice coping skills in a safe environment with a counselor. That can be very helpful too.
So if one is burdened because of a loved one who clearly is moving further in the continuum from substance use to substance misuse, and the word is misuse, not abuse.
Misuse, not abuse.
Misuse.
Mm-hmm. Yep.
You tell everybody this is interesting for me to learn this, because a lot of this is like, but anyway, because one of the first things I did when I knew I was in was I stood up and I said, my name is Janyne and I'm an alcoholic. And that is it's in all the movies. It's one of the first lines you cross that says you get it. And so it's just interesting, because I don't have a problem with being called that, because I've crossed that line. But anyway, what do you say to people who are here who have loved ones who are struggling with substance misuse and are trying to help them, or either force them or encourage them, what their kids could be at risk, whatever that is, to get help? What would you recommend to those individuals?
Yeah, so they may not like what I have to recommend, which is to not do what we see on TV, which is, the intervention, the staging of the intervention, which is what we all see on TV. Because what the research shows is actually something that confrontational leads to the opposite effect. And so people will actually retreat and not want anything to do with what you are wanting them to do. So allyship, again, harm reduction, meeting them where they're at, right? So identifying your concerns, right? And your concerns are always valid. They're not blaming of the person, right? You are sharing, like, these are my concerns about what I'm seeing. I don't know what's actually happening, but this is just what I'm seeing, and I'm concerned about you. And I just want you to know that I'm here to help, and I'm here to listen. And if there's anything I can do, just let me know, because I would like to help you. And leaving that door open, because when that individual is ready, they will know to come to you, because they know that you are not being judgmental. They know that you are there for them and loving them unconditionally, regardless of what might be going on. And we have seen this even just with patients as well, right? That maybe are not ready to even admit that they have a problem. And then only over time do they feel comfortable enough to say something, because we haven't been pushing them. We've just kept the door open. And that is what seems to be the most effective strategy.
So that's interesting. I remember finding little brochures around the house that my mom would put here. She was a nurse, and I've never asked her if she did that intentionally for me, but that warmed me up for the process to get help. But even as I hear that, I also think about enabling behaviors. So what is the difference between saying I'm here to support you and to help you and being an enabler?
Also an excellent question. And I know this is something that Alan and Al-Anon is discussed at length,
Yeah.
and so from just speaking to family members of patients, that is a line that's very delicate. And so again, I think sticking to what are your concerns, right? There's a difference, I think, between, letting your adult child live with you rent free, without a job, without a structure to their day, while they are using substances actively, right? I think there's a difference between saying, hey, I'm here to help you, when you're ready, and then just letting them continue to live rent free, right? I mean, there has to be some sort of responsibility on their part as an adult, right? That you can use substances, but you still have to contribute, and that's part of the policy of living here, right? And so I think there's a difference there, that somebody can still be under your roof and can still be using substances, but must have some sort of contribution, whatever it is that you decide is necessary. Because I think allowing them to just continue that behavior without anything, that to me would be enabling.
So I guess I'm going to ask you one more question, and then I'm going to pop up the website that you referenced that has a 1-800 number. What gives you hope? What gives you the most hope? Because the numbers we're seeing for the volume of alcohol sales post-pandemic, there's a graphic that I included in one of the announcement emails that clearly shows a spike in opioid addictions after the pandemic. And how are we even getting that information? Because of the pandemic, people are, I mean, it's just so interesting. It'll be interesting when we actually get that data. So in the midst of what is really quite horrible, because if you were in my world when I was caught, it was a horrible, horrible world. In my soul, in my spirit, I was functional, but it was horrible. What gives you the most hope today?
So I have a lot of hope. And what gives me hope is seeing my patients recover, is seeing the fact that recovery is not only possible, it is probable, right? And it is likely if you get the support that you need, and you get evidence-based care, and you surround yourselves with individuals who are able to help you in the way that you need. And so, I think many times we have this idea of what it means to have a substance use disorder, and it's all negative, right? Everything that we envision is negative. But I get to see the positive side of it, right? I get to see people turn their lives around and maintain their jobs and have employment and their families, and just be who they are and have a meaningful life again. And being able to be a part of that and to help them do that is just magic. It truly is magical. And that is what gives me the most hope, is just seeing that recovery.
Well, first let me share the slide. This is the website that corresponds with the 1-800 number for I think do you call it SAMHSA? Is that what
SAMHSA? SAMHSA, yep.
And it's interesting because the one thing that you didn't like about the site is what it's called: substance abuse and mental health services, instead of substance use disorder. But I
Yep.
want you to see that in the bottom here, there's a place to click on to find treatment in your area. If um, uh, if uh, if you or someone you love is struggling with thoughts of ending their life, as I struggled with, then there's a National Suicide Prevention Lifeline, behavioral health treatment services, and a national hotline here. And so the website is SAM HSA, is that right?
Yep.
SAMHSA.gov. And the
Yep.
phone number again is 1-800, is it 622-HELP?
662 help.
Help
Yep.
that you can turn to. You know, I had never heard of substance use disorder. And literally, I was talking to a friend a couple months ago, Susan Courtney, who some of you know because she has been a guest on some of these webinars. And she said, you know, Janyne, I heard somebody speak about something different. And she was trying to remember what it was called, substance use disorder. And I pull it up on my phone, I Google it, and I see this scale. And I'm like, I mean, in my gut, it was like, this is so different than what is so deeply ingrained in me. And so I decided to lean into it and to learn, how is it different? Is it possible that it works? And so thank you. As soon as I reached out to Dr. Balasanova, she said, absolutely, I will be there to help. And so I encourage all of you, if you need help, access this website to get help, or we'll make this video available as well that you'll be able to share with others. So we're here to be helpful to you with new, even better information, evidence-based information that can help people who either love somebody who is struggling with substance use disorder or somebody who is struggling themselves. And so I'm going to ask you to hang on 1 second before I thank you, but I want to remind everybody that next month we will have our Professional Women Connect Global, and I'm excited for our guest, and we'll be announcing that shortly. And then in July, we're going to have our second annual Gratitude Summit, the neuroscience of being thankful and the difference that that can make in your life. And so you'll be receiving emails that will inform you about the dates and let you register, et cetera. But as we wrap up today, I really want to thank you, Dr. Balasanova. I want to thank you for the work, the research that you have done, and for the vision that you have cast for helping people who are caught in the grip of substance use disorder. I hope that all of you find help and hope from the science that Dr. Balasanova has shared. And we hope to see you again in the future as we continue to deal with the hard issues that leaders face. And substance use disorder is not, executives are not immune from having substance use disorder for themselves or for the people that they love in their world. And so thank you. And thank you so much for your time. You're literally like less than a mile away from me. And I look forward one of these days to actually being able to see you and to thank you. Thank you everyone for joining us today. We will see you in June.
Thank you.
Bye-bye. Thank you so much.